Okay, so I want to say Womanjika to you. Womanjika Wurundjeri Beek. And that means welcome to Wurundjeri country. And I'm speaking from Wurundjeri Woiwurrung country. You'll see that's the east of Melbourne, and I'm based in Box Hill. So that's between Melbourne and Corranderk. I want to acknowledge the traditional owners of this land where I live and work and play on, and thank them for their custodianship of the land. And I also want to pay my respects not only to the elders out there, but to any First Nations people who are joining us online tonight. So what are we going to learn tonight? I'm hoping you're going to go away with the following outcomes. To understand the surgery undertaken for the management of lipedema and its effect on the subcutaneous tissues. Okay, so subcutaneous tissues means your skin, your fat, and everything under it. To understand why therapy is required in the pre and post-operative periods, and to understand where, when, and how sequential intermittent pneumatic compression, which is a mouthful, so I'm now going to call it after this point pumps, how pumps fit into the management of the pre and post-operative surgical management of lipedema. So we think surgery is quite new here in Australia, but it's not. It was actually back in 2002 in Paris that the first results for this new liposuction surgery were presented. The Germans were the real early instigators of this surgery, and then slowly the rest of the world's followed. We now have Dutch guidelines, the UK, the US, and also the Canadian, all telling us that surgery is now a component of lipedema care. Now, when we talk about liposuction, there is not one style of treatment. That's really important to know. And I'm going to talk to you about the different surgeons in a moment that work in Australia. They all do things a little bit differently. So the first thing I want to bring up is something called tumescence. And that's the first three pictures on the top row there. This is about putting tumescence into the tissues. So before they even take the fat out, the doctors put a cannula in, a small one, more like a big needle, and they infiltrate some solution into the tissue. So you can see that going in there, and you can see that tissue expand with that solution. And that solution has some special chemicals in it, and they're designed to stop the blood flow as much, so you're not going to lose a lot of blood. They're also designed to give you some painkiller, which is great after your surgery because it's got a numbing effect. And they're also there to balloon and expand that tissue up. And they blow you up a little bit like a watermelon with this. And that's to make sure it's a lymphatic sparing surgery. So if they can blow the fat tissue up away from all the blood vessels and all the lymphatic vessels, they can then get the cannula in and take out the fat more carefully and more successfully without lymphatic damage. Okay. And slowly after the time of that tumescence is put in, all that fluid's got to come out. So we know that when you're having this type of surgery, we're putting more fluid into the tissue. So that's what tumescence is. I'm going to show you a picture of it in a minute on a patient. Some people do it dry though, and a dry technique means they don't do this tumescence infiltration. Now, once they've got that tumescence in, they may choose different techniques to get the fat out. The one on the left there, the vibrating cannula with the green arrow around it, is our power-assisted liposuction. Think of that as a jackhammer that goes in and it vibrates and jackhammers out the fat. The second picture is, you can see the water jet there. So they put the cannula in and it sprays a very high water jet into the tissues, and it's like pressure jetting, say, your garage or a wall or your driveway. They're actually using the water to really blast away those fat cells and then suck them out. There's also laser or vaser techniques. I don't know of anybody doing that who's registered in Australia for liposuction, for lipedema treatment, but I know it happens in the States. So I'm not going to talk about that one tonight. So this is somebody who's had tumescence. The patient and Dr. Lekich have been very generous in letting me have some photos to use for teaching purposes. The picture on the left is this lady's decided she's going to have her lower legs done first. And the pen marks show that she's marked up where the bones are and where they're going to do the surgery. The middle picture shows that her left leg's already done. So she's got some puncture marks there, and that one's been reduced. But the one on the right hasn't been reduced yet. And you can probably see from the second picture to the one on the left that the tissue is much more turgid. It's much more blown up, a bit like a watermelon full of fluid. And that's that tumescence. And then the final picture, both legs have been completed with the liposuction treatment. So that's the tumescence. So who are the surgeons in Australia? We've got a number now. So we've got Mr. Cheyenne based in Melbourne. We've got Mr. Samaya in Sydney. Thomas Lamb's in Sydney. Chris Leckage up at the Gold Coast. And Beryl Tan in Melbourne. And there they all are. This is our team across the country now, which is great because girls previously were flying off to Germany to have this treatment, or people have been flying into state. And now we've got at least 3 of our states, we've got surgeons in. So this is absolutely fantastic. They all do things very differently. Okay, some of the doctors do not take a skin incision and take skin away, and some do. Some do both legs at the same time, and some do only one at a time. So you need to choose the surgeon that's right for you. And how do you do that? You're going to ask a lot of questions. So I don't often say go on Facebook and find out some information, but I do find a lot of my patients have got a lot of good information about choosing a surgeon and the pros and cons of different surgery by talking to women online who've already had this done in Australia. And the group is very active and it's a good source of information. You can get some basic information, and then what I would do is discuss that with your therapist about, I'm thinking of using such and such a surgeon. What do you think? Do you think that's right for me? Look, some of your therapists aren't going to be very experienced with this, so they may say get more information. And I've done telehealth with patients to try and help people come up with a decision of what's right for them. But I think the biggest question to ask yourself is, how big are my legs? Which surgeons do the size of those legs? What's my BMI, my body mass index? And does the surgeon undertake that type of surgery on my BMI, or do I need to lose some tummy weight first? And then the next question to ask is, have I got really big legs? And therefore I might need a skin lift when all that fat is taken out. And from that, you can start working out who you want to see. We haven't got time tonight to go into every protocol, but I hope that gives you a start of something to start with. So we've got some research to date now. Quite a few papers have come out regarding liposuction for lipedema. So we're going to go through, what do we know? So we know the water and power-assisted liposuctions are safe for patients. We know they reduce your limb size, but interestingly, when they take the dysfunctional fat out, pain and bruising go down as well, which is really interesting. Because the size reduces, you can move better. Your gait patterns, so your walking patterns better, and your joints are in a better alignment for it, so your joint pains improve. And your quality of life improves because you've got less pain, less bruising, and you can walk better and less joint pain. Obviously, your shape improves. And because your proportions normalize, a lot of women find their self-esteem improves afterwards because they're looking and feeling better. And Dadras did a study in 2017, and he found that some patients can actually totally omit their therapy, or they can reduce the therapy they need, or it's spaced out after having this surgery. And we've found that happens more in stage 2 lipedema patients than stage 3, because more of our stage 3 patients have had more permanent joint damage, and more of our stage 3 patients have got more permanent lymphatic problems and lymphedema, which still needs treatment even though they take the fat out. So when should you consider surgery? You might be sitting on the fence. A lot of my patients do, and we talk this through together. So Birch has said, Tobias Birch is one of the German researchers, and he said, you should still have pain despite 6 months therapy. So what he's really saying is, don't go into this without trying some therapy first. We do see patients who've worked really hard on the lipedema with therapy, diet, exercise, weight management, and compression, and their pain really settles down, but they still have surgery to reduce the volume of their legs. You need to have therapy with your liposuction, okay? You can't do it without. You need to be ready psychologically. It's a big procedure. You need to be worked up psychosocially. And by that, I mean, if you're living alone with no one to help you, we need to consider that, because you're going to need help after your operations. We need to look at your diet to get you in tip-top health so that you bounce back quickly. And also exercise as well to get those muscles working and get you in the tip-top health again, so we recover quicker from your therapy, from your surgery, sorry. Now, the big one is obesity must not predominate your lipedema. Many women with lipedema do have a bit of a tummy. Some ladies with lipedema have a large tummy. And we know that 88% of our lipedema patients have some form of obesity. We know with the new low carb and ketogenic diets that we can lose that tummy fat. And a lot of ladies can lose some fat off their legs. So we want that treated. We want that you're working on that to try and get your BMI down as low as possible, to put you at less risk of side effects from your surgery. And that's what nobody needs, is any side effects, especially on your heart and lungs. Because remember, you're going to need an anesthetic. Now, the guidelines state that your BMI should be under 32. And many of you be looking at that thinking, there's no chance on this planet. I'm 40, I'm 50. But the most of it is on my legs. And what we do now is we measure your waist-hip ratio or your waist-height ratio. And we can then say, look, this lady's got a BMI of 45, but the fat's predominantly on her bottom and her legs. So we can justify that. And that's how the doctors will look at it with you. You also need to prove your weight's been stable for 2 years, because Anne Pelled did a lovely study in 2016, and she found if you let your weight creep back up after your operation, the improvements are lost. So we must try and make sure that your weight's stable before that, and do all that hard work before you pay the thousands and thousands of dollars it costs for this surgery. It's basically the price of a new kitchen. And we need to be psychologically ready. Some of you I know out there have tried everything under the sun to reduce your lipedema. And some of you have got binge eating disorders or have been anorexic or bulimic. And we must ensure that that's all under control before you have your surgery, because we know that severe problems in those areas reduce success. Now, I've got a gory slide. I want to show you the difference between the fat. Gory slides aren't for everybody. So I'm going to give you a chance now. If you see blood and things on the television and you don't feel very well, please look away. I'm going to put this slide on in a moment, and I'm going to let you know when it's gone. So I hope you've all looked away by now if you don't want to see it. So this is the fat that comes out during the operation. And I want you to look at the slide on the left. That's Dr. Leckage, and he's got a lot of bags of fat out of one lady's legs. Look at that fat. Look how creamy yellow buttery it is on the top. Now, all that pink fluid underneath, that's that tumescence, and he does the water-assisted liposuction. So that's the tumescence, and all of that water he's put in the tissues with a bit of blood that's he's sucked out as well. On the right is a slide of one of the patients I went into surgery with that was very different to the ones I saw with Dr. Leckage. And this is a lady who I would say was a stage 3-4 lady, very big legs, very bumpy fibrotic fat. Does that look the same as the buttery stuff? I don't think so. It actually looked like bits of plastic coming up the tube, and that's the scar tissue within the fat that comes out. Now, Mr. Cheyenne uses a power-assisted technique, and you can see that there's a lot less fluid down the bottom because he doesn't put fluid into the tissues, he only puts the tumescence in. But you can see that fat is very different. We want you to work on your fat preoperatively to soften it up. And Karen Herbst talks about this, about fat therapy, to manipulate that scar tissue in the fat and try and soften it up. Because I tell you now, the doctors want your fat to come out buttery. It comes out much easier with less bruising to you. And you can really see when the doctors hit patches of the really hard fat, they work really hard to try and get it out of you. So let's move on. Gory slides gone, everybody. So I want to tell you about a challenge we have as therapists and doctors. I've talked about Facebook group being really good to learn about the surgery, but I want you to be aware that some of these social media chat rooms can be a bit of a problem for you as a patient, because it's patients learning from patients. And there are some preconceived ideas and some fake news out there. There's a lot of myths going around. So if you're hearing things about surgery and you're not sure, or about pumps or treatment, talk to your therapist about it to get the truth. I've also had quite a number of patients coming in saying, I must get this garment because their online friend used it and it worked well for them. Lipoedema is a spectrum. There's lots of different shapes and sizes of it. And what works for one lady doesn't always work for another. And I also know there's a bit of a black market out there for wraps and garments that people have used for surgery and they don't need anymore. And I want you to think about, is that cheap garment online a good thing to do for hygiene? Incorrect fit, it could be incorrect pressure, it could be the wrong fabric for you. So think about that. I know that your therapy is really expensive, the products aren't cheap, but we want everything to go well and you not to get an infection. So I just wanted to highlight that to you. Beware. Okay, let's get back to therapy. So Anne Williams did a paper in 2019 and I got really excited because I thought this is going to tell me what to do. And she did a critical study of summary of 10 studies around liposuction. And unfortunately, I was waiting for the answer and there isn't one. There's still no worldwide recommendations about what we should and shouldn't be doing. But like Nicola said earlier, this is an evolving field. Watch this space. When I know about it, you're going to be the first to know about it. We do need a randomized controlled trial on this. What we did have when I first started working with the surgeons many years ago now was the German therapy protocol, because remember, they were the early instigators of this surgery. Now, the Germans used the flat knit class 2 compression pre-op, so before you're up for 6 weeks, to get your inflammation down in your tissues, to squeeze out any lymphedema that might be there, to soften up the tissues and get them ready for surgery. Then they have a wonderful system. In you go, you have your surgery, and they have the ability to make you custom-made flat knit pantyhose. They get measured in the hospital on day 2. And because all the garment providers that make these custom-made are in Germany and in Switzerland and places like that, they can email them the measurements, on the go they make them, and overnight they get them couriered to the hospital. So they wake up day 3 in these custom-made garments that they've been measured the day before, and they wear them with absorbent pads 24 hours a day. You might need a bit of over-bandaging on that. What a glorious system. I wish we had that here. They go on and have MLD for 4 to 6 weeks. And look, there's various protocols. Some of the doctors say daily, some say 3 times a week, some say once a week, and one of the doctors says use acoustic wave therapy. So they're all doing different things. And what we know is those custom-made garments need to be worn 24 hours a day for 6 to 8 weeks, because everybody, whether you've got swelling before the operation or not, swells up after this surgery. You cannot put a cannula down and take out all that fat under your skin without having some swelling. It's like injuring the skin. And then we start to wean you 24-hour-a-day compression about that time. And it's around 6 to 8 weeks. And then once your incisions have healed, you can go back to your sports and your swimming and your exercises. So in 2015, I realized quite quickly, I can't do that. because we don't have the garment providers here to make us things like that. So I had to think, what is going to be my best practice protocol? So I got the literature out. That's what I do. I like the research. And the research said there's some post-operative complications. So I thought, well, my job is to try and help reduce that. I can't really help the intra and post-operative bleeding because that's going to happen whatever. Again, some ladies lose more blood than others in the operation, depending on how aggressive the surgeon has to go in to get that hardened fat out. And so if you do get hypovolemia or low hemoglobin, that means they've had to go in very aggressively, or they've moved a very large volume. And by large volume, they reckon around 5.4 litres of fat out of your legs. That's who's at risk of that. And I can't change that. We also get very big bruises called hematomas. Now, that's obvious because you guys out there bruise very, very easily. But we can also get seromas, which is a pocket of fluid building up. And I think, well, that's where I can get involved to try and reduce the chances of that happening and get them to settle down quicker. I have to watch for infection, which is very, very low. You can see there only 1.4% get an abscess. And we also know that after the operation, it's very common to have very sensitive, tender skin, what we call allodynia. And we know from Alex Munnock's in the UK papers that he does liposuction for lymphedema as well. He tells us that his patients with lipedema have higher post-operative pain than the lymphedema ladies. And that's because a lot of you are sensitive to touch to start with. It's part of the lipedema syndrome. And the big thing that I can get involved with you with therapy to try and reduce is to try and reduce that post-operative swelling or edema, which we know peaks at 7 to 10 days after your operation. So that was my job, try and reduce complications. The second thing that therapists can help you with is try to prevent your fatty tissue getting too swollen and thick swelling, induration, and excess scar tissue formation. But really what I was looking at is that we do a do no harm approach. So we want to, in the early post-operative period, we want to have some adaptable compression because you're going to swell up. We want to try and stop that swelling, but bring it down. So it's got to be able to adapt. It's got to cover the foot. Even if you don't have any fluid in your foot, I know a lot of you wear footless compression preoperatively and just for your general compression, but you must cover the foot after this operation because the bruising will run down into your foot. I'm going to show you a picture of that in a minute. You can use your pump to get rid of the fluid. You've got MLD and I've got laser as well. We shouldn't really call it laser. It's called photobiomodulation. And we can do that to help with your hematomas and seromas. And then later, we're going to look at scar tissue management, get you exercising again, get your custom flat knits sorted out, and keep you working on your own ongoing weight management. So that was my best practice protocol in 2015. And to be honest, it hasn't changed much since then. Here's the bruising picture. Big, big bruises. This lady's only had her lower legs done by Dr. Leckage, but look at her feet on the left and look at her around her ankles and her heels. She was a naughty girl and didn't put her foot compression on, and you can see that bruising has tracked right down to her toes. So you have to wear the compression we prescribe you, and you can see her feet are quite puffy as well from not using that. But that's what you can expect from bruising. And you can see the puncture marks on her skin from where the cannulas have gone in. So Dr. Leckage doesn't do a skin lift. So this is what his surgery looks like. This is the scar you can expect from Mr. Cheyenne. He does some of the biggest legs and he does the skin lift. The one on the left is where he's had to do the skin lift right down to the ankle. And the one on the right is the general one that he does that goes at least down to the knee. So if anybody tells me that you're having this surgery for cosmetic reasons, you're not. This is a salvage operation to keep you mobile and to remove the fat and reduce the pain in your legs. We all got together, the therapists in Melbourne in 2015, and said, what are you doing? Because Mr. Cheyenne started doing this, and what do we know is certain, and how can we improve this? And this was the outcome of our roundtable meeting. The certainties are that you are all individuals, and there is no recipe for the right thing to do. I'm going to show you some pictures to describe that later. You do have to have an understanding of your surgical procedure. We have to communicate with the surgical team, and you do too, to make sure things are going well. And we never presume that somebody who is medical trained knows how to put on a wrap or a bandage. Sometimes they ended up upside down in the early days. And we know that your compression and your equipment is costly on top of your surgical fees. The uncertainties we had is, do we use bandages to adapt to the shape, or do we use wraps? I tend to prefer wraps because you guys can get them on and off easier. Others like the bandages. Do we do MLD or pumps or both? And what was the transition time to the flat knit garment? We think now probably about 6 to 8 weeks. Some are more, some are less. Now, these uncertainties were influenced by the therapist, the client location. So that the Melbourneites, it's easy, they can come and see me. But I've got people who've had surgery in Mildura, interstate, Gippsland, all over the place. And they couldn't maybe use MLD because they couldn't come in and see me as often, or there wasn't a local MLD therapist. And it might be as well that you're having your surgery, but your therapist's actually booked to go to a conference or on holiday. And these are all things we've got to take into account when you're booking your surgery. Check your therapist's going to be available afterwards. They can always move your date a little bit. So this is what I said about being an individual. Look at the 3 ladies who aren't on the pump. They've all got completely different legs, and they've all got lipoedema. They've all had completely different scenarios and treatments to deal with the size of the legs they got and the problems they had. So you do have to go and see a therapist way before your surgery so we can get everything organised in time. And what we do depends on your surgeon's protocols. So we've got to have something adaptable that's not going to rub against wounds. If, like the lady on the top left, that you're having the skin incision with Mr. Cheyenne, and the lady on the bottom, we need to know what's planned. Are we having a full leg, or are we having part of leg done? Which leg's being done first? And what's the size of that leg? How much fat is the surgeon thinking he's going to get out? And when we pull a tape measure really, really tight to try and guess how much your leg's shape's going to change to get the appropriate wrap device, we need to work all this out. And what I do with my patients is I get all my patients to get a pump at least 2 weeks before their operation to help move any fluid, to help the circulation and get rid of pain before the operation, but also to let you know what it feels like before your operation. The last thing you want to do is wake up with a big scar and wound down your leg and try and put a pump over that, not knowing what it feels like. You need to know what it feels like on your normal leg first. So what do we do with pumps? I use MediRent pumps a lot because they rent them to you and you don't have to buy them. So there's the biocompression pants. And these are the ones I would try and get my patients into because they generally do the liposuction right up into your bottom area. So you want the bottom covered. So they've got multiple chambers, 8 per leg, 16 altogether when you've got 2 legs there, and we can get it custom made. So don't think that we can't get a size for you, because we can have it custom made. And then there's also the LX900, which used to be called the LX9. And this comes in just legs and with a separate abdominal bit. And there's 4 chambers in each of those garments per leg. So we've got 8 chambers in each. And some ladies prefer this if they feel a bit claustrophobic in the tummy part, or they're just having maybe starting with the lower legs done. That's where this one comes in handy. Or if they've not got much of a bottom and the surgeon says, we're not going to take much fat away right in the bottom area. It's going to be mainly your thighs and your legs. You don't need the bit over the abdomen as much. So how do you get one of these pumps? There's a referral process. You need to be referred by your therapist, and there's special forms to fill in for all of these different items. They need to fill in the right ones. So if you're a therapist online, just be aware that the ones in green you can see on the left, they're the LX900, and the turquoise ones are for the biocompression pants. And you do need to fill in the correct form. Measurements need to be taken and filled in, and settings need to be written down by the therapist. So what I do with my patients is I bring them in and they have a trial of the pump with me in the practice. And I say to them, what can we tolerate from pressure? We write all of this down. It goes off to MediRent, who will set the pump up for you on those settings, ready for it to be delivered. And all you've got to do is press the button when it comes. Now, what pressures do we use? Generally, we try and start you off on 40 unless you're very, very tender in your tissues. We know that's safe. Most people find it comfortable and it's effective for fluid movement. If you look at the little circle on the right, that's showing us what pressure should you need. So if we get it up to 40 when the sleeve is fully inflated on your leg and you say, oh yes, that feels firm enough, I wouldn't want to have that any tighter, that's the pressure for you. But if you think, no, actually it could be a bit tighter, we can go up to 50 millimeters of mercury. We just increase by 10. Now what's important is you don't decide after 30 seconds, you think, oh, I'll put it up again, because your tissues have got to get used to that. And sometimes after 10 minutes, it might not be so happy at a higher pressure. So allow it to run for about 10 minutes on that adjusted setting. And then after that, you think again, right, is it firm when it's fully inflated? And you can decide, yes, stay at the pressure. No, it could be tighter. Or you might think, oh, 50, yes. Actually, that's feeling a bit too tight now and it's causing pain. You would decrease back by 10 to 40. And that's how we gauge your pressures with you. I want to reiterate that higher is not better. Modes and settings. Now, this is the beauty of a MediRent pump, is you've got lots of different options. Our A mode starts at the top and clears the top like a pre-treatment. So it clears the top of your limb. This is the traditional way how we treat lymphedema. So if you've got lymphedema, you might need an A mode. B mode starts at the bottom and it pushes slowly by inflating the segments up your leg. And that's what we call the classic sequential. Now, we know that lipedema ladies generally have a normal lymphatic system anatomically. So it means you're not missing bits or got no nodes like lymphedema patients have. It's generally that your lymphatic system is overloaded. So you may well be able to do the B mode quite successfully by just helping your lymphatic system by pushing it up to the top. Our C mode is really helpful if, say, your foot or ankle's the really swollen bit. It squeezes a number of times on the foot and then it'll push it up the leg. So it's very good at clearing fluid right from the bottom. And D's a little bit different. It's for pain management and it works in a wave. So they're the different settings. And you're going to work with your therapist to try and choose the right setting for you. And it changes through your post-operative period. Generally, I'll send people away trying B before the operation, but depending on where their fluid pockets are after the surgery, I mix up all these different treatments. And every time somebody sees me, I might be changing them up onto a different mode to get the best for you. So lower pressures are generally used with our patients to maintain your volume if you've got compression garments. And if you've got very little free fluid or edema there, but you've got pain and sensitivity in your tissues. And we use that more for inflammation and pain management. Whereas your higher pressures are for those of you who've got really hard lymphedema areas and your shape isn't very well maintained and you've got stagnant fluid that looks like orange peel, maybe in the base of the lobes, the lumps and bumps of your lipedema. And what I mean by that is a picture like this. This lady, you can see the dots on her inner knees. Those dots are what we call the orange peel skin. And this lady had lymphedema, and she had big, big pockets of edema on those knees, which were very, very firm. And she needed quite a pressure to get those shifting and moving and softening up. But if you're very, very sensitive in your tissues, we've got to find a pressure that's comfortable for you. So we'll drop it right down to maybe 20 and run some daily treatments for about an hour a day to desensitize your tissues, ready to do some more down the track. Now, be patient. We are aiming for pain-free compression. And then slowly, as you find your pains dropping and the inflammation in your tissues is dissipating and the circulation's coming in and the fluids dissipating, we can start putting that pressure up just like we did in the diagram before in 10 millimeter increments, and just keep reviewing like we did with that circle. Where am I? Is it too tight? Is it just right? Or is it not enough? And when the treatment's comfortable and effective, you do not need to turn it up more. Now, I'll mention the custom made. There is no leg shape that we can't fit for the Medi-Rent biocompression with the custom made. There they are, making them in the factory. What we do is generally, if it's not the best fit, we'll rent the best fit option, knowing that we're going to get a custom made, and then reduce any of the lymphedema down with intensive pump use at home. And when we think your size has changed and you've reduced down, that's when we remeasure you for your custom sizing. And then continue to use the pump using the best fit option garment while you're waiting for your custom fit garment to arrive. And then when it arrives, you send the best fit one back, the stock size one back. So you're never without a pump. Now, many of you have got a tummy like this lady. And I want to talk about tummies because they're very, very important with edema management. What we know is when you've got a big tummy like this lady that hangs down a little bit, it squashes the lymph nodes in your groin. And that's what the picture in the middle is showing. All that pressure into the lymph nodes of the groin, it reduces lymphatic flow. And we can get obesity-related lymphedema with people that don't have lipedema because of this fact. And what we want to do is lift that tummy up to allow the flow to happen better. And how do we do that? We put your garment on. So this lady's got some Bioflect lightweight garments she can put on that have really sucked that tummy in. And then she puts the pump on over that. So we're going to get the best drainage for her. The other thing to note, if you've got a very big tummy, is that sitting up in the chair might not be the best position for you to do your pumping in. You might need to be reclined back 45 degrees again to take the tummy pressure off your inguinal lymph nodes. So not like the lady on the left, like the lady on the right. She's lying back a little bit to make sure she's getting the best treatment. Okay, moving on to edema management challenge after surgery. So you've learned that we start probably preoperatively between 40 and 60 millimeters with the pressure. Post-op, though, you're going to be in pain. So we're going to go back to that, reducing the pressure down very low because you've just had an operation. So what I tell my ladies to do is not the first day after your operation when you feel battered and bruised and you're getting rid of the anaesthetic out your system and you're still bandaged up and the doctor hasn't been to see you. But the next day when he takes your bandages off, that's when you're going to start getting your pump out and starting. It depends. If you're in a lot of pain, you're not going to be able to do it. But we start back at that 20 millimeters and we start building up slowly, slowly over the weeks till you get back to what you were doing preoperatively. Like I say, we change up the modes and the cycles and the speeds especially. If you've been doing a very, very slow speed with your therapist because your fluid's very thick and hard and indurated, you're going to find we're going to need to change it post-operatively because you're going to have very soft fluid at the beginning. If it does hang around a bit and it gets indurated and you've got a thick patch left that won't shift, that's when we turn the cycle time down a little bit. I frequently use a speed 2. And like I've said, we're going to try all the different modes. Your therapist is going to guide you, and that will change over your post-operative period to get the best effect. But see, this does require therapist knowledge. So you do need a therapist to help you with this. You cannot do this by yourself. How long? We've said 6 to 8 weeks, because we want your post-operative size to stabilize, for all that fluid to come down. And it's not until the 6 to 8 week period you're going to know what your legs really are going to look like after surgery. And that's usually the time we get your custom made garments. I normally get my ladies to say, even if you don't desperately need the pump, hang on to it till your custom made garments have been ordered and received, and you've got them on and you say, yeah, they fit. And that's when I'll say, okay, let's start maybe doing every other day and see how you go without it. But if you're having your surgery, if you're up in Queensland and it's always hot, you might need it a bit longer. But if you're like me, a Melbourneite, and it's freezing in the winter, you're going to need a longer hire in the summertime when it's hot, because we swell more when it's hot. And lipoedema definitely tends to have more swelling when it's hot. You also need to keep your compression garments on 24 hours a day. Oh, sorry. That's really important. If you start taking things off, the fluid will start coming back, or it won't move. So you can't start taking things off. That's really important. People think they're okay, and then they come and see me. I say, why have you taken that off? Your fluid's still really high. So I'm going to do 2 quick case studies and follow through a lady that when things went smoothly, and one where maybe not so smooth, and show you where the differences lie with using pumps. So this is one of my stage 1 girls. She doesn't look like she's got a lot of volume from the front, but when you look at her from behind, you can see the disproportion around her knees and on the sides of her hips. And that was her leg after she had her surgery with Mr. Cheyenne. Full leg. Look at the size difference. Look how bruised and swollen she is on that leg. So for those of you who say, oh, I don't think I'll get any bruising or swelling, you will, even if you're a stage 1. And she did really well. You can see her, she's in the green here. So this is how we measure fluid with the bioimpedance machine. The green means in the normal. And she wrapped herself and pumped twice a day. And you can see right at the end there where she has her operations, one leg's still in the green a bit higher, and the other one just goes in the yellow. So she had hardly any fluid. For the therapists out there that do know moisture meter, you can see her TDC readings, but were between 29 and 52. So brilliant, not a lot of fluid there at a post-op. And up in her inguinal region, it was 33 to 36, whereas, yes, as we expect, down at the bottom with gravity around her malleoli, it was 49 and 50. So she had a little bit of fluid down at the bottom, but she managed it brilliantly. She was one of my stars. Now, the second case study, unfortunately, we can't use her pictures. She hasn't consented for that. But this picture shows what her legs approximately were like before a surgery. And you may be able to identify with this kind of shape a bit more of a stage 2. This lady had a rocky road, and I'm going to show you the difference, which I hope you'll see from the slide of a graph. It's a completely different graph. We've got a lot of the dots are in the red and the yellow there. Let's start at the beginning on the left. So you can see her left leg was just above 6.5 in the yellow before her operation. So she had some fluid in there, very mild, whereas the right leg's right down in the green on the bottom, and showing that her right leg was a good leg, not so much fluid in that leg. And what we did was that preoperative pump trial with her, and look, her fluid went down. Amazing, on both legs. So took the fluid component out even more. Go back to the top to see her left leg, and you'll see that line shoots up into the red. She had her left leg done first. She had pain, a lot of pain, which she thought she wasn't going to experience. She told me preoperatively she had a very high pain tolerance, but even then she had a lot of pain, and she had a very rough post-operative early ride. We couldn't get the pump started because of all of this pain, so her edema was allowed to build up. And then as well, she decided that she wasn't going to keep her wraps on, that she wanted to use an old thigh-high stocking, And at night, she was using a knee-high stocking. That was not what she was told, but she wanted to do that. And you can see she's still in the red. We have a delay. Then COVID hit, and this lady worked in a hospital. She had to go back early to work. She was working shifts in full PPE, and it was hot, and she couldn't use her wraps. And she continued to pump, but look at all that fluid still in the red. And we had to have a chat to her, and I said, okay, COVID's hit. You can't wear your wraps. We're going to have to get you out of the wraps earlier than I would normally do. I would normally wait till she was back in the green before we would get her back into get her out of the wraps and into a custom made. So what we did, I'm going to tell you about the carbs in a minute. I'll just go back to the top there. We put her in an early flat knit and kept pumping, and that's when the lines started falling. Now, what was interesting when she was coming in for a left leg was you get your right leg measured anyway, and her right leg hadn't had any operation and was having the pump on it. But look at that. Twice fluids went up in her leg, and we worked out she was eating carbs at those times. And carbs really affected this lady, as we know a lot of you find. So we talked about that. And she said, I'm going to be careful with the carbs for my second op. She went in and had a second op for her right leg. And you can see now on the bottom graph, look how she's only gone a little bit into the red. So she's gone from the yellow into the red. And even with that op, she had a bit of a rocky ride. She had a low hemoglobin, felt quite wobbly and had some delayed healing. But she didn't have as much pain. She got the pump on, and look how that line comes down. So we know the pump really helps when you can get it on early. She did have some carbs, and look what happened here. She'd been staying with family who tend to give her carbs, and this was the pattern with this lady. Up it went to the red. I said, what are you doing? It's worse. She said, it's the carbs again. So she got back on a keto, and look at both legs, both graphs drop on the keto. You can see as well, the left leg has a little jump above on the top graph as well with the carbs. So carbs really affect this lady's fluid. And then with a revision touch-up on both legs where they take out any stubborn patches of fat, as a third operation, that's a much smaller operation. She hardly moved on her fluids. She was good. So she kept her pump for many, many months to get through this period. And she's bought a pump to keep on top of her fluids long term. So you can see how the pump works there. Now, this is the hemosiderin staining we can get when you've had a really, really bad bruise. It leaves a brown staining. This is what I use the laser on, and we get you doing some deep massage down the track. You can also see the two little scars on the leg left there from where the cannula's gone in. So this is months down the track. That's what the scars look like on your leg if you don't have a skin lift. And you need to wear your shorts. So this lady was given shorts to wear. You can see how skinny her leg is up to the thigh, but where she hasn't worn her shorts, she's full of fluid. And look at that orange peely skin on the thigh. They're my handprints pushed deep into that fluid, and horrible bruising, but look how little bruising she's got further down. So it shows what your compression does and what happens if you don't wear it. It's absolutely imperative. So I hope I've given you an overview about how we work with you after surgery, with pumps and with wraps and with compression. We have this anecdotal do no harm consensus, and that's all the best we've got at the moment, but it may change. Watch this space. We know that pumps are safe and effective for managing that post-operative edema, and it does promote you having self-management. And definitely these ladies don't come and have much MLD with me. I might see them every 2 weeks unless they're having big problems. And we can adapt it for the complex post-operative roller coaster that sometimes can arise when you get problems as well. So if you've got any questions, I'll take them now. And obviously you can send your emails through to MediRent, or if you've got questions, the phone numbers are there. Okay. And I'll put that disclaimer up to leave. Thank you.
Thank you so much, Helen. That's been really interesting. We've got a few questions flowing and some of them we've answered, but I'll just have a quick look through. There's been a couple of questions about tissue and how you know how soft it is. Just wondering if you had a comment about that.
Your hands. So as a therapist, these are my most valuable assets. Our hands are going to feel for you and be able to tell. As a patient, you don't know whether your fat's soft or not. As therapists, I have 25 years experience in these hands, so I can have a good feel and tell you whether your fat's harder compared to other people's, more lumpy. We press and look for fluid and see the consistency of your tissue. So really, you need to get someone to look at your legs to guide you whether you've got very bumpy, lumpy fat to work on, very soft fat to work on, or whether you've got soft edema with it or thickened edema with it, because all of the treatments for that are different.
There are a couple of questions around low-level laser with lipoedema, possibly in general, and also post-surgically, and whether that was effective.
Yeah. So we know, I'll just say PBM, that's what we're meant to call it, low-level laser, is really good anti-inflammatory treatment. What I will say is that you shouldn't have it just on its own. If you're not wearing a compression with it, it's not a great idea because that inflammation is going to come back. You need to be moving with it as well. So we do use it as a sort of what we call an adjunct treatment on top of our standard get moving, trying to do whatever movement you can to pump the blood flow through your fat and flush out those inflammatory chemicals. With your diet, if you're eating a lot of processed food and putting more inflammation in, I wouldn't be choosing laser first. I would be getting you moving, I would be getting your compression on, and I would be getting the inflammatory aspects of your diet down first. But if you're doing all of that, if you've got your garments on, you've got a pump, you're doing the low carb diets, you don't eat processed food, and you're moving much as you can, and you've still got a lot of pain, give it a go to see if it helps you, or to give it a go to see if you can get your pump up higher to clear the inflammation as well. So it's there, and post-operatively I use it a lot to get those hematomas down and heal them, to get rid of the inflammation in those levels. And I work on it a bit higher on those brown hemosiderin staining areas to try and break that up, and then get my fingers in to break it up to get those tissues in good health.
Good stuff. This is a comment to Natalie directly. You've asked about whether MLD should be used or pumps. I think that Helen has answered this pretty well during the session, and the session is being recorded. So you will be able to watch the whole thing again and hear all her comments. But there was also a question around whether pumps could be used on their own instead of MLD if you lived remotely.
That's what I have to do with my remote clients, and that's why I like pumps for self-management. Like I said, I've had people very remote. There is nobody to do MLD, and that's more detrimental for that person to drive 3-4 hours to find a therapist being still in the car with their legs down and vertical, which is going to make them swell. So we've got to do that risk analysis benefit for those patients. So if you're very rural, you've got to think, I'm going to swell. That's not good. You'd be better off using the pump, but you still need a therapist to look after you. So you're going to have to see somebody so they can guide you with that. There's only so much we can do with telehealth. We need those hands on those tissues, and we need to be doing some measurements to be able to be guiding you correctly.
Yeah. There was a question around whether you can continue to use lymph taping with the pump at the same time. Have you had that experience?
Absolutely. So lymph taping's different. We're meant to be lifting the skin to try and get flow through the skin. So look, if you're using it to lift the skin, you can use a pump safely with it, but you've got to think about what you're doing. Why are we lifting the skin and then squeezing it at the same time? So there's do no harm. You can do it, but you need to think why you would do it, because it's two different theories and they're going to knock each other out.
Now there is a question from someone, And I suppose this might relate to a few people who may have had surgery in the past, not having their lipedema diagnosed. So in this situation, she's had a thigh lift and then is just wondering now that she knows she has lipedema and she's put the weight back on her legs, whether there would be any impact on the lymphatics or anything for going forward.
Yeah, so this is what happens. Women don't know they've had lipedema. I've seen this a number of times. A woman's had plastic surgery years ago, just trying to deal with the body shape for cosmetic purposes. And then no compression, didn't know that they should be doing low carb diet, anything like that. And you've gained weight and it comes back. And that's what Anne Peled says. You've got to look after yourself after. It's not the miracle cure. You've got a genetic predisposition to make your fat grow more. You've got to keep it under check as much as we can. But that lady, it's hard. I don't know a scenario. Let's just say she's had a dry technique done, which I would probably guess she has, where they didn't put the tumescence in. You're going to have some scar tissue there. And you would need to discuss that if you want further surgery with your surgeon, because that could be a problem where you might bleed a little bit more where they're going through old scar tissue. From a therapy point of view, if you're not going to have surgery, we're going to have to assess you and we've got all tools now. You need to find a therapist who might have the moisture meter and the bioimpedance, so we can actually locally look at those areas to see, is there a problem with your lymphatics from that surgery or not? And it may be there's not, and you've got away with it and you're lucky, but your treatment will still be the same. If you've got lymphedema, we're going to deal with it. If you haven't, we're working on more inflammation and exercise and in the diet component without needing much MLD or lymphatic care.
Good stuff. There's been a couple of questions about which therapist we might recommend in other states besides where you are, Helen. And I, for one...
Golden question every time, isn't it, Nicola?
I'm not going to get any of my valued therapists offside by recommending one over the other.
I would say, as I always say, you need to contact Lipoedema Australia, who have a list of trusted therapists around Australia who are known to work intensively with ladies with lipedema. That's what you need to do. If there's nobody near you on that list, the other place to look is the National Lymphoedema Practitioner Register, and that's on the Australasian Lymphology Association website, which is lymphology.org.au. And you can put in your postcode with a 500-kilometre radius, especially if you're rural, and it will tell you if there's somebody who's accredited in lymphedema who at least will have knowledge of lipedema to work with you and be safe with you.
Yeah, good stuff. I think we may be slowing down on the questions, but there was a comment about your beautiful hair, which is purple, to support raising awareness for Lipedema Awareness Month, which I meant to mention at the start of this session, and it's the reason we're holding this webinar tonight. So it's been a fantastic month. The Lipedema Association of Australia has been doing great things to bring awareness to the rest of our communities around the country. And so Helen and MediRent, we certainly support that cause.
Absolutely. And if you do want to sponsor me for having purple hair at the minute, I'm leaving the sponsorship page open for another month. If you look up Helen Eason Goes Purple for Lipedema Australia, it's on my cause. You can donate even $2 there. If you have trouble finding that site, you can find the links. It's all over my social medias at the minute. So you can find me on Twitter. I'm Helen Eason Physiotherapy on Facebook, and I'm Helen Eason on LinkedIn. So find it, click on the blue link. I'm really excited as I've met my target amount that I wanted to get today. But let's leave it open and see if we can get even more money to get this GP awareness program funded. So it's been a great day today.
Good stuff, Helen. There's one last question if you've got time. It touches on the start of your presentation where you mentioned vaso liposuction, and the question is whether it removes lipedema tissue.
Well, I don't know really much about this. It's been quite controversial in the US. There's some surgeons up in arms saying it's damaging, and there's other surgeons are swearing by it. So it hasn't really hit the shores here. I'm not sure if it is or not going to hit the shores here. But yeah, we can't get it in Australia, and I wouldn't certainly be recommending that at the moment. I just put that in to let you know it's out there. And yeah, I think the jury's out. There's one team saying yes, there's one team saying no. We'll see if they make their minds up in time.
Yeah. Excellent. All right. Well, thank you so much, Helen, for your time. I think that everyone's got a lot out of the session this evening. And like I say, we will be posting that recording in due course on YouTube if anyone wants to view it again, or those who missed out, of course. So thank you, and have a wonderful evening.
Thank you.